Emergency, 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 emergency. Patient, what do you do?
What do we do? So we call the hospital, let them know that we are in a STEMI. We have 10 minutes to do the EKG, give them aspirin, nitro, and actually notify the ER doc. And then we transmit the EKG to them. They confirm it's a code STEMI, and we go straight to the cath lab and let the cardiologist take care of the heart attack.
Cool.
Hello, welcome to Cath Lab, where we're going to fix you. Welcome to Cath Lab. I know you're having pain. We're going to get you taken care of. First thing, there's going to be a whole lot going on. We're going to get your clothes down, get you shaved, get you prepped up, get you taking your vitals, getting all equipment ready, and we're going to go inside your heart and stop that heart attack. I know it's a lot. I know it's scary. We're going to take care of you.
And then go from there.
My name is Kelly. Welcome to Cath Lab. What I'm going to explain to you is how we're going to do this procedure and what exactly to expect. We have you on the table. We ask you to lay flat. Keep your hands down to the side. We appreciate the help. We don't need any extra help. We're going to be quick about this because your heart is in trouble and we're here to fix it for you. We're going to get you all your clothes off so that it doesn't hinder your care. We're going to cover you up with warm blankets. We're going to shave you from basically your navel button to your knees to make sure everything is clean. Hair causes an infection. We don't want you to get an infection. We don't want you to get that drape stuck to you. We're going to clean both areas off of your femoral areas, basically from here to here, and make sure it's clean and sterile. We're going to cover you with a big blue sterile drape. It's going to go from your neck down beyond your feet. We're going to go inside for a little poke here. You're going to feel some numbing, but you shouldn't feel any pain after that. We're going to give you some medicine called Versed and fentanyl, and that's going to take the pain and the awareness away, and it'll relax you. You may feel tired, go ahead and take a nap. You may feel some warmth inside of you, you may feel some chest pressure. If you do feel that, you let us know. When we're inside your heart, we're going to take pictures. Of these pictures, we're going to look at and see what part is blocked and what is not blocked. If there's a blockage and if we're able to fix it, we're going to try to fix it. Sometimes the blockages can't be fixed. We're going to take you to the operating room emergently to save your heart. After the procedure, we're going to have you lay flat because we don't want you to have any problems bleeding in your groin area where we're working. You'll be recovering. You're going to be kind of relaxed for a while. Make sure that your heart can recover because your heart's had damage. You'll be in bed probably about the next 6 to 8 hours recovering, depending if we still have you on a lot of blood thinners or a little bit of blood thinners. Your family can come in and see you. You'll be able to eat. If you have any chest pain or problems afterwards, you tell your nurses so that we can come back up and fix what might be a problem again. Sometimes your body reacts differently, and it can cause a clot in there again after we work, sometimes not. Any questions? You want to go through and drape? You have sort of it's a sheath. It's got a one-way valve on it, so this is actually going to be in your artery in your leg. This little hub is going to stick out. The side port allows us to flush and administer medications if we need to. With the one-way valve, it keeps your blood on the inside and allows us to pass wires and catheters in and out to be able to fix your heart. This is heparinized saline. The heparin keeps from blood clots forming on any of the equipment that we use. These are our contrast delivery devices. What it is it's a little push button, allows us to give the contrast in small doses instead of all at once, keeps the waste down. These are the catheters. They're actually anatomically correct. And what they do is they go from your femoral artery up through your aorta, down into your ascending aorta, and clip into your heart. And this actually is anatomically correct to clip into your right coronary artery. And it's going to inject your right coronary. This is the left one. This will also go through your femoral artery, up through your ascending aorta, and it clips in like that to allow us to inject your left coronary system. These are diagnostic-only catheters. We do not pass any wires or devices through them. This here's a pigtail. This sets down into your left ventricle and actually allows us to give a large amount of contrast in a short amount of time to actually see the function, the muscle, the squeeze of the muscle of your heart to see how well your heart's functioning and how strong your muscle is. This is our access needle. It's 2.5 inches long that bevel up. That's how we access. And we can pass a wire through there once we have the artery. We'll poke in like that, the blood will come out here, the wire will go in there, we'll pull the needle out, and we just put a soft sheath in there afterwards. Put a wire.
So you see? So you put flushed again.
It's hard when it's dry.
Yeah, I know.
The wire goes through there, and then we'll pull the wire, and this wire will be hanging out of your artery. And then we'll put all our equipment over top of that, the sheath. Over top like that. And we'll pull it out. And it'll just be sticking out of your leg. But that's how we essentially get it in without causing trauma. This is our big drape. These are plastic coverings that we use to cover our equipment to keep it from getting blood. We keep a sterile field. We want to keep everything safe and clean for the patient. As far as other devices we have here, we have access needles, we have sharps, we have clips, really not a whole lot. We have cups ready for nitroglycerin that we administer, we have lidocaine that we start with. We can pretty much administer medications through the intracoronary arteries. These are our prep sticks. It's cool. Pop them, snap them. Here. And they turn. Oh, they turn orange. So how we're going to prep your femoral artery. The orange tells us where it's clean. It's going to be active up to 48 hours. And we throw them. Yep. Both sides, left their femoral areas. We won't do Erica's femoral artery. Direct coronary arteries, that is our contrast medium. It is clear, but this is what happens when it dries, and this is what can happen in the body is it can get all dried and sit in the kidneys, and if it's not flushed out properly, ultimately the patient can end up in dialysis. Of our stent and balloon variety, we have some stents that are bare metal stents that are about $800 to $900 a piece. Those are bare metals, no drugs on them. The drug-coated stents can go anywhere from $1,200 to $1,500. Those are bare stents that have a drug coating on the inside of them to help decrease the scar tissue regrowth inside of that artery once that stent has been placed. That's one of the balloons that goes inside your leg to try to open it up. Gotcha. Your body has to exert that much pressure inward as this is pushing outward. Gotcha. Otherwise, we're going to rupture that vessel. That's right. Isn't that amazing? That is amazing. And it's usually about 100 psi. It's pretty tight.
All right, deploy.
Welcome to Cath Lab. I know you're having pain. We're going to get you taken care of. First thing, there's going to be a whole lot going on. We're going to get your clothes down, get you shaved, get you prepped up, get you taking your vitals, getting all equipment ready, and we're going to go inside your heart and stop that heart attack. I know it's a lot. I know it's scary. We're going to take care of you. You're so cute. Oh my God. All the way down. All the way down. There we go. Over. Pretty cool, huh? That is. Now this part usually has sticky stuff and it's attached to the patient. We're not attaching it to Eric. Put your jeans on you. Alright, touching your foot. This is all work zone down here. It's pretty cool. You're not doing it?
Sure. Can I have that in my legs tomorrow when I'm out, right? No kidding.
Are we on these tables? Meanwhile, they're breathing well. We're watching what their sedation is, giving them medication. We're in and out of their heart with one of these catheters. These catheters actually be up here in their heart taking pictures. And we're down here injecting. Probably table.
Okay. So yeah, are you recording it? So we should record. Well, that's stuff that goes with it.
You're going to feel a little pinch and a burn here, okay? First you're going to feel my fingers. I'm going to feel through your femoral pulse. So if your pulse, I'm going to give you some numbing medicine. You're going to feel that. It's going to get numb, okay? Where it burns, it'll go numb. You shouldn't feel any pain after that. You're going to feel a little pressure. You shouldn't feel any pain. You can scream if you want. After that, we'll have blood flowing back. A little pressure. The worst part's done. All the poking's done. There. Sheath is in. You shouldn't feel any pain now, okay?
No pain, just...
Is a heart attack, and this is the left side of their system, and these are all the different vessels. Like this controls the left side of their left ventricle and the lateral wall of their heart. This vessel here is the whole anterior part of their heart, the whole top side of their heart. And this is actually looks pretty good for that person. Now I'll get to the part that's actually not good. This person here, if they're having a heart attack, here's a narrowing, but right here there's actually clot sitting down in the bottom of their heart. And that's not good for that patient, so we need to go in and get that out. This here shows the actual squeeze muscle of that person's heart. You can see the bottom side, it isn't squeezing as well as the top side is. There's a couple spots that are blank, and that's where that clot is sitting. He's got a little bit of damage to that heart muscle. This whole top part of the heart wall was actually squeezing quite well. Here's the actual aortic root, and this is what is the part of the ascending aorta which goes out and feeds that blood to the rest of their body. We're actually in the main pumping chamber of their heart. When that person with the clot sitting at the bottom of their heart, this is actually what happens to the electrical system. That's mimicking an actual massive heart attack. And that's when that heart attack is peaking. Intubation kit, if someone stops breathing, we can bag them with an ambu bag, which, okay, if you want to demonstrate that, you can pull it out. Basically, a freeze for the patient. There's a mask that goes over them. We call respiratory. They come up and actually put a tube down their throat, which is a secured airway. That way, if they throw up, if they vomit, no extra stuff is going to get in their lungs, which can cause major problems. So we have an intubation kit which has all different sizes. It has the ability to do that. We have drugs, needles, equipment, IV stuff. You name it, what we're going to need for a code is going to be in there. Medications to make their heart rate go up, to make their pressure go up. Anything to help us. Most important part is going to be the defibrillator. Patient goes into a lethal rhythm, we have to make sure that we get them out of that or they die. We have shock pads that go on the patient that we put them on their back and on their side to stay out of the x-ray pictures. And they're attached to this. We can either use paddles, which are pretty cool. They yell, "Charge!" You gotta shock the patient. Demonstrate how they are used. You can test them. I can show you basically an essential what a shock looks like. Usually we start at about 120 to 150 joules. Right now, for a test purpose, I'll show you that. All clear. Not shocking. And it'll record basically what rhythm the patient was in, when they came out of it, the date and the time on these papers, part of the patient's chart. Ambu bag if they're not breathing. This goes over the patient's mouth. You can squeeze it in and out. The tube on the back is attached to oxygen so they can get 100% oxygen. This way we can breathe for the patient and make sure that they are still getting enough oxygenation that they need while we're waiting for respirator to get here to put them on a ventilator.
We would respond to a patient having symptoms and
A patient calls 911 having chest pain, shortness of breath, diaphoretic. EMS gets there, they get on scene, they do an EKG on them, put them on oxygen, give them some nitroglycerin, give them some morphine, give them some aspirin. Recognize they have ST elevation, call a cardiac alert, call the hospital, let them know we're coming in. The hospital will call the cardiac team to roll. We have to be here within 30 minutes, so they're responding in. The patient's being driven to the hospital. They get to the ER. Within 5 minutes of hitting the ER doors, they have to have an EKG. When they determine that, the doctor will say, it is legit, we are going to bring the cardiac team and send them upstairs. In the ER, they're going to prep the patient, get all their clothes off, get them on an IV drip, give them 5,000 of heparin, make sure that they have the aspirin. If they did not, they're going to give them the 4 doses of baby aspirin, which is 324 milligrams. They're going to give them up to 3 doses of low pressor, which is a beta blocker to help with their heart. They're going to come up to cath lab. We're going to get them on the table, do our cardiac procedure, see if their arteries are blocked, and if they're blocked, we're going to open them. If we're unable to open that patient's arteries and they're still having excruciating pain, they're going to go to the open heart surgery and try to valve them out and get their heart fixed and stabilized. Again, when we realize that they need open heart surgery, we're going to call for the OR team. We're going to get a surgeon, we're going to get the PAs, we're going to get the open heart team here. They again have 30 minutes to respond. So we're going to stabilize this patient in the cath lab until they go to open heart. When they go to open heart, they're going to get the bypass procedure done, spend 2 to 3 days in the CVRU unit, which is cardiovascular recovery unit. They're still going to be intubated, pretty much put in a medical coma, and then recovered to 5D. Within a week they should be out of the hospital, depending as to how weakened their cardiac muscle is. After that, they go to the rehab. For a cardiac cath patient, after we open up that artery, we are going to send them down to a recovery unit, whether it's CCU, which is a cardiac care unit, or 3D, which is our cardiac step-down unit. They're going to get recovered within 2 to 3 days, again, be out of the hospital. They'll spend about 2 weeks in cardiac rehab with a new set of medications, some life-altering changes such as, stop smoking,